Guys are ready.
Hi, this is Megan Crane, Zero Suicide Program Coordinator for Oregon Health Authority Public Health. I am happy to be putting on the second assistance webinar for school-based health center school-based centers with the Public Health Division School-Based Health Center Program and Suicide Prevention Program, and happy to have Adam Lesser with the Columbia Lighthouse Project with us again. Today's webinar will focus on the Stanley Brown Safety Planning Intervention. First, just have a couple slides for us to go through before we pass it on to Adam. So just a reminder, through the Public Health Division, we have injury data available. It hasn't updated since our last webinar with most data points have been updated with 2016 data. And this is just a reminder as a way that you can look at what suicide rates are looking like in your community and what unique factors there may be in or other social factors that you may want to take into account when considering your suicide prevention or intervention efforts. Next slide. I want to remind folks of the At-Risk and Primary Care Adolescent Cognito Online program that we have. I guess is a short online experience that really goes through motivational interviewing with a teen and how to approach that conversation in a way that will solicit truthful responses in a way that will make the teen feel comfortable. As you can see the picture here, you have this scenario with the adolescent and the caregiver. Next slide. Come up for you to get information or respond to what the adolescent is saying, where you choose from in order to move the conversation forward. Really about building rapport with the patient, talk about mental health and correct common misconceptions, appropriate ways to ask the patient about suicidal ideation, and take appropriate steps for referral and follow-up. And then within this conversation, the adolescent, you can actually click on the thought bubble above the adolescent's head to kind of see how they think the conversation is going, as well as there being a monitor at the bottom of the screen where you can just kind of see the anxiety level of the teen. There also is a helper you'll see at the bottom there that will pop up to say how, whatever question you kind of to your own adventure you took, how that solicited a positive or a negative response. And you can also go back and try different approaches to see how the teen reacts. Really just an opportunity for folks to practice that conversation, see what works for them, and kind of learn from Cognito and adapt it into their workflow. Next. So again, the simulation is free to all school-based health center staff in Oregon. You can access the program through cognito.com/Oregon. You'll see this pop-up page. You do have to create a login already, but again, the program is free. Next slide. In the yourself section, you would just want to choose your training POV or point of view as primary care professional. Next. And then a couple questions. One, your institution and all school-based health centers should be in the drop-down menu. Your role is, and there is CME available for this program as well. Next. I wanted to remind folks that we are hosting a Oregon Zero Suicide Academy in September. Again, Zero Suicide is really looking at quality improvement around suicide, safer care within healthcare organizations. I would encourage school-based health centers and school-based health centers that are attached to larger healthcare organizations to consider applying, and happy to talk to folks about this opportunity and see if it's appropriate for them. We're also, after the Academy, going to be hosting a Oregon Community of Practice for Better Suicide Care to kind of allow organizations to get together to talk about how zero suicide or suicide safer care initiatives are going, get support from one another, and learn how lessons learned from organizations that are currently putting suicide in effect. So application can be found on the website, or actually I'll maybe get to Kate when she sends out the link for a copy of the application so people can look at that as well. With that, I will pass it over to Kate.
Thanks. Hi, this is Kate O'Donnell from the State School-Based Program. I just wanted to make a note about minor consent and confidentiality in Oregon. Adam will speak a little bit about what this means in the context of safety planning, but just a reminder that in a healthcare setting, Oregon has some unique laws related to consent and confidentiality, specifically for mental health services, that minors 14 years or older may consent for outpatient mental health treatment. Consent is not the same as confidentiality, however. So Oregon law does not have a legal right to disclosure or a legal right to confidentiality. The law really says that providers should use their best judgment when disclosing information. However, in the context of mental health, are expected to involve parents at some point in the minor's treatment. And so that is, unless there is obviously clear indications to the contrary, and the law lists that out. It is also important to disclose, and I'm sure folks are very aware of this, if you are a mandatory reporter, which I'm sure many of you are, that you would have to disclose certain information if you felt that it was the student was a threat to themselves or to someone else. We do have a document that pretty helpfully outlines Oregon minor right and consent to health care and confidentiality, which is what's pictured on the right. My contact information is in a couple of slides, and if you're interested in seeing that or receiving paper copy, I'm happy to do so. Next slide. I also just wanted to mention the American Academy of Pediatrics recently updated their guidelines for depression screening in primary care settings. They have just recommended that providers universally screen for depression for adolescents 12 to 24. They've had guidelines for about a decade, and this is the first time they've updated them. A piece of that is also safety planning. And so if a kiddo pings on your depression screen, one important piece of that is doing a safety plan. And so hopefully this webinar will help provide some of the tools if you are on the primary care side for what that looks like. Next slide. And we also just wanted you to save the date. We will be doing a follow-up to the CSSRS webinar that we did a couple weeks ago. We had a lot of great feedback and a lot of participants who said that they just wanted more information about the practical application of this tool. And so save the date for August 8th from 7:30 to 9 a.m. We will be putting on this webinar again very graciously with Adam and the Columbia Lighthouse Project. And if you're not able to make it, we will also have a recording of the webinar available on the State School-Based Health Center Program website. Next slide. And here's Megan and my contact information. If you have questions about zero suicide, you can contact Megan, or if you have any questions about school-based health centers and school-based mental health, you can contact me. Thank you very much. We will turn it to Adam now.
Great, thank you. The both of you have been doing some amazing work and providing some excellent guidance for the school-based clinicians that you work with. So we're going to talk about safety planning in this webinar. Traditionally, in suicide prevention efforts, we've had things like population-based prevention, like public service announcements or highway billboards. We've had population screening, identification and assessment of individuals who are at risk. That's where things like the CSSRS are used, followed by emergency care through emergency departments or hotlines, with potential treatment being psychiatric hospitalization or outpatient treatment with specialized psychotherapy and psychopharmacology. But what we're going to focus on today is a different type of intervention, one that we call a brief intervention, and this one in particular called safety planning. Interventions in general range from one session to multiple sessions. They may or may not include any type of follow-up support, and they tend to use a variety of different intervention approaches. They use psychoeducation as a method. They provide often crisis response planning steps. They use cognitive behavioral therapy and motivational interviewing to engage somebody and encourage them to return for treatment. And they can use things like outreach follow-up, things like letters or postcards or phone calls to clients. The rationale for brief interventions has been that sometimes the crisis contact that you have with a student may be the only contact that that person has with the mental health system or a caring provider. Because suicidal patients in general are difficult to engage in treatment. Up to 60% of suicide attempters don't even attend more than 1 week of treatment after discharge from the ED. And after a year, 3/4 of them won't continue in any kind of treatment. And we know that ongoing outpatient treatment is not appropriate for everyone. That for men and for certain cultures, there's still a stigma connected to Western psychotherapy. Individuals with borderline personality disorder who are definitely at high risk for suicide and suicide attempts also are difficult to engage and maintain in relationship-based treatment models. And adolescents tend to have attitudes that are inconsistent with long-term therapy. They tend to believe that the past is the past and that things that happened a year ago or 2 years ago or even 6 months ago aren't going to happen again. And when they start to feel better, it's hard for them to imagine that things can get worse. They don't have that sort of forethought looking towards the future. And finally, treatments just may not be available during high-risk times for people. There may be a long wait list for outpatient mental health treatment. They may be in a rural community where they just don't have good access. So having a brief intervention that you can do when they are in crisis and presenting to you can make a big difference. The typical strategy we used to have for crisis intervention was you assess them for imminent danger, and then you refer them for treatment, right, either for outpatient or for inpatient. But given the limited success of those ED referrals, there needed to be alternative strategies, and we're including immediate intervention that ought to be considered and available. At the time, though, it's important not to expect miracles from these brief interventions. They should be considered just one aspect of suicide prevention, the same way cholesterol-lowering drugs are one aspect of cardiac disease prevention. You still need exercise and dietary changes when you have high cholesterol, but those drugs really do help and can make a difference. So, a particular safety plan intervention that we're talking about has two goals in mind. The first being to reduce suicide risk and enhance someone's coping skills, and secondly, to increase their treatment motivation, to enhance the connection that they feel between you and them, or your organization and them. None of this safety plan intervention that we're talking about, it was developed by Barbara Stanley and Greg Brown. Barbara Stanley is here at Columbia, and Greg Brown is at University of Pennsylvania, works in Aaron Beck's group there. And they designed this to maintain the safety of high-risk patients in 2 outpatient treatment trials, one being the Penn CT study for adults, and the second being the TASA study for suicidal adolescents. The TASA study is also the study that birthed the CSSRS. And what the safety plan is it's a compilation and an ordering of evidence-based interventions that had been used in the past, but they'd been used sort of separately, and this is putting them together and providing a order for them. And it was expanded and modified so it can stand alone as an intervention initially for the VA, and then also for civilian emergency departments, but has been used widely by lots of other health providers in the past couple of years. 3 theoretical approaches behind it. First one being that suicide risk will fluctuate over time. That's a diathesis stress model of suicidal behavior that was developed by John Mann. And what that means is that, we all have these underlying risks or risk factors or propensities towards suicidal thoughts or behaviors. Things like our diagnosis of a mental disorder, our family history of perhaps suicide, our own background as far as traumas go. And then what happens is a current stressor, like a relationship breakup or a divorce or a sudden arrest or incarceration comes, and that stress then sort of pushes things over the edge and creates this suicidal crisis. The second theory behind it is that problem-solving capacity diminishes during a crisis, right? You can't think about what you're going to do when you're in that sort of panicky crisis moment. And this reminds me of some work that I have done in the past with the Red Cross doing disaster mental health work. And, one of the Red Cross's mottos is that, the last place that you want to be meeting your team and developing a plan is in the middle of the flood. Right? You need to have these things in place before the crisis happens. And that cognitive behavioral approaches are effective in making behavior change. That behavioral strategies can be used to identify stressors that precipitated suicidal thoughts or behaviors in the past, and that together with the individual, you can determine cognitive behavioral strategies to manage them the next time they might arise. The evidence base that is behind the steps in this safety plan are 4 evidence-based suicide risk reduction strategies that have been proven to be effective. First being means restriction or means safety. What that is putting a little bit of extra time between someone who is starting to feel suicidal and them having the lethal means that they would use in their hands available to them. Second being teaching brief problem solving and coping skills, that when you teach somebody things like distraction, they can use those to enhance their coping. Enhanced social support and identifying emergency contacts, that when you have your social support and emergency contacts carefully laid out for you, you will do better. And finally, motivational enhancement for further treatment, developing a connection so that they can come for further counseling if necessary. In an overview, this is an intervention where the individual who's at risk creates this one-page document with the help of a clinician that they can use the next time they're in crisis. It's a list of coping strategies and resources that are a stepwise increase from things that they can do just on their own up to going to a psychiatric ER or calling 911. And though it's a stepwise plan, if one step's unavailable, it's important not to stop and wait until that step becomes available and to move on to see if you can reduce the stress that you're under. It's a very concrete and tangible intervention. This is what the one-page form might look like. It is brief and easy to read. It's written in the individual's own words. You can use it in just one session with someone, or you can incorporate it into ongoing treatment with somebody. So if you will see them again, you can continue to revise the safety plan. It provides a sense of control, and similar to other risk safety measures like a fire drill, we believe that if you practice these kinds of things, they become much more easy to do when the crisis arises. Like a cast for suicidal patients, right? It's when you break a bone and you go to the ER, they set your bone in a cast and send you home, and the healing really happens at home. And that's how this sort of works. It's a cast for dealing with suicidal crises. It can provide this immediate intervention to someone who doesn't need to be hospitalized, and it fills that gap, perhaps, between their evaluation in your office and any follow-up treatment that they might have. If they're not going to go into the inpatient unit and they're going to be going home, this gives them something that they can use to keep themselves safe until they have their next appointment. What it's not is this safety plan intervention is not a substitute for treatment. It can't help if the individual is in imminent danger of attempting suicide, and it's not a no suicide contract. We used to just have these no suicide contracts that we used. I remember using them when I first got out of social work school, and these were pieces of paper where we would ask our clients to sign and promise that they wouldn't try to kill themselves until their next appointment, or if they thought they were going to kill themselves, they would call first. What we know from the last decade of research is that these types of no suicide contracts are not effective at all. They don't reduce the risk of somebody making a suicide attempt in the same way that these actual safety plan interventions do. Can use this for is really anybody that might be at increased risk for having suicidal thoughts, but doesn't require immediate rescue or hospitalization. Somebody who's made a suicide attempt, who's had suicidal thoughts in the moderate to high range, have had any kind of psychiatric disorder that increases their risk, or have otherwise been determined to be at risk. You may want to do it with somebody, even if they've never been suicidal before, who has depression and a family history of suicide, because there are enough risk factors there for it to warrant it. And when you begin to do that, you'll first have the individual describe the events and the situations that and their reactions to those events in as much detail as possible. And that's what helps build the rapport between you and this student, and creates the buy-in that they'll participate in this process. You start with the sort of major decision point that got them into your office. What brought you here? What prompted you to come and get some help? What was going on? And usually it's a strong emotional reaction to some specific event. Like I said earlier, some kind of loss or stressor. And you'll follow backwards in time and ask questions about, what was going on right before that, and what did you notice right before that, and what had happened then. And you'll create this sort of detective style questioning about how did you get from being relatively okay, which I know you were a few days ago, to this crisis. And they tell the story. It helps you to understand the function of their behavior from their perspective. That behavior made sense to them in the context of their history, their vulnerability, and their circumstances. It'll allow you to empathize with their strong feelings and their desire to reduce distress. You have to validate in this step for them that they were trying their best to get out of a crisis situation, that they wanted to feel better, wanted their pain to end, and that they just didn't know what to do. And it's important in this step to refrain from trying to solve their problems. This is if what precipitated the suicidal crisis was a relationship breakup, this is not the step to say, there are more fish in the sea, you can do better than them, maybe you should try this. This is just listening to their story and hearing about how they ended up this way. And so when you are going to develop this plan, you assess with like the CSSRS to see if they need to go to the hospital, and if they don't, then you can ask them if it's okay if they develop this plan with you, and explain the rationale for this plan, and that they'll use it the next time they notice that they're beginning to escalate. There are 6 steps in this plan. The first being how to recognize warning signs. The second being what internal coping strategies you can use without needing to contact any other individual. The third being socializing with others who may offer support as well as distraction from their stress. The fourth being contacting family members or friends who may help to resolve the ongoing crisis. And the fifth being contacting mental health professionals or agencies. And then the sixth step being to reduce their potential for having lethal means available to them. So step 1, recognizing the warning signs. You can only use a safety plan, right, if you can recognize what those warning signs are and see the crisis coming. So after you've heard that entire story about the events that went on before, during, and after their crisis, you'll ask them things like, how will you know when you should use your safety plan? What do you experience when you start to think about suicide or feel extremely distressed? And, have them be very specific and document the thoughts, the images, their moods, their behaviors in their own words. So Dr. Stanley and Brown did an evaluation of 100 safety plans that were written by veterans in the VA emergency room. And so that you can see the types of thoughts that they were explaining were primarily depressed or hopeless or worthless thoughts, so some of these real negative thoughts, followed by reminders of their past trauma. The emotions that they said they felt were being angry or irritable or frustrated, followed by feeling depressed or anxious, overwhelmed. Sensations that they described were panicky type sensations, as well as pain or headaches or weakness, fatigue. And some of the external cues that they identified were stress is caused by another person or an event, or feeling financially stressed, having some kind of physical contact with another person. And you've described all the things that precipitated so that they can, sort of see if this is going to happen again. You'll do step 2, which is using internal coping strategies. The activities that an individual can do without having to contact another person. The activities function as a way to help them take their mind off their problems and promote meaning in their life. So they are coping strategies that you hope will distract them and prevent their ideation from escalating. It's useful for them to try to cope on their own and do this step, even if it's just for a brief time, because it can help them to feel some self-reliance and efficacy, that they, have some kind of power over these urges, and that there's, something that they can do on their, by themselves to perhaps make it a little better. So you'll ask them, what can you do on your own if you become suicidal again to help you not act on those thoughts? How likely do you think it is you'll be able to do this step, and what might get in the way? And use a problem-solving approach to make sure that there aren't any roadblocks to being able to do these things. So if what they say is, I really love to paint, you want to make sure that they have access to paints and canvas or paper. That when they have these crises, they'll be ready to do those things that they list as their distractions. So the veterans that Dr. Brown and Stanley looked at said things like watching TV or movies, taking a walk, listening to music, exercising, playing video games, doing schoolwork, meditating or deep breathing, doing chores, something creative like crafting, some kind of self-care or self-soothing activities like massage or taking a shower or bath, looking at photos, spending time with pets, all the kinds of things that you would expect might help somebody to, to de-stress and to feel better. Then step 3 is using socialization as a means to distract and support. And so step 2 doesn't resolve the crisis enough, then they'll move on to step 3. Step 3 is not where they reveal their suicidal thoughts. It's just socialization to take their mind off their problems. And the reason why we have people do this before they call their best friend and say, that they're in crisis and, this is what's going on, is because if, as soon as they notice they're escalating, the first thing they do is jump to calling that, one best friend or that one family member. They're going to burn that relationship out. And so we want them to try to do something social to distract themselves before they jump to talking about what's going on. So there are 2 options in the step, the first being that they would go to a healthy social setting, and the second being that they would contact family or friends that may offer support or distraction from the crisis. So socializing with family members or others, you'll ask them, who helps take your mind off your problems for a little while? Who do you like to socialize with? Who do you like to hang out with? And have them list a few people in case they can't get in touch with the first person on the list. And then as far as health social settings, you say, where could you go that's a healthy environment to have some social interaction? Are there places or groups that you can go to take your problems off your mind, even if it's just for a bit? And have them list also several in case, one's not open. And have them remember to emphasize they should be healthy settings. We don't want them going to go somewhere where there might be risks to them, where the local hangout where kids drink or, is not a kind of safe setting for somebody who might be having suicidal thoughts. And so the veterans said things like going to hang with a family member, with a friend or roommate or neighbor, with a spouse or significant other, with a support group member or religious person. And they said they'd go to places like a library or bookstore, to a park, to a place of worship or community center, to the theater, a movie theater or other kind of theater, to a store or mall, to go shopping, go to a restaurant or a coffee shop, go to someone else's house, to the gym, to a support group meeting, all kinds of social environments where they could distract themselves. After step 3, if step 3 doesn't resolve the crisis enough, then you'll have them to contact family members or friends and say, please help, I'm in a crisis. And the rationale for this step is that we want them to practice using their natural helping environment before stepping up to calling, their therapist or going to the ER. And so ask them, how likely would you be willing to talk to these folks? Do they know what's going on for you? Have you talked with them in the past? Identify any obstacles and problems that might be in the way of them reaching out to these folks. And it's important to encourage them to share this safety plan with the people that they put on this list, that they feel that they'll come to if they're in a crisis, so that those folks know that this is a possibility. So that these individuals can say, hey, if that does happen, what do you, want me to do? What's helpful for you? Or they can also get the resources that they might need to be a help to this individual. step 5, contacting professionals and agencies. If step 4 doesn't resolve the crisis enough, then you'll want to activate your, your mental health care team. So which clinicians go on your safety plan? What kind of obstacles would there be to calling them? If it's on a night or a weekend, do you know what to do? List the names and numbers of all of the providers, as well as the local emergency department and the suicide prevention hotlines, 1-800-273-8255, or text 741-7441. 6 is reducing the potential for the use of lethal means. The rationale for placing the lethal mean restriction at the end of the safety plan is that if individuals have a sense of the alternatives to their behavior, they're more likely to talk with you about means restriction. If the first thing you talk about with somebody is, oh, do you have access to guns, it's not likely that they'll be cooperative in that discussion. And so we place it at the end after they've developed a rapport and a relationship with you through going through the other steps. And the main idea is, again, to put some distance or time between someone suicidal and having the means in their possession. And so you ask them what means they would consider using or have considered in the past during suicidal crises. And regardless whether they name it or not, you should always ask if they have access to a firearm because of the high lethality of such a method. So for methods with low lethality, you can ask them to remove or restrict their own access to these methods. So for example, if they're considering pills, you can discuss, getting rid of any extra pills that they don't need. You can talk about can they have someone hold their prescriptions and give them just, a few days or a week at a time to hold on their own. You can have them talk with parents about, not giving responsibility of holding all of their own pills. Or you can even go to the pharmacy and ask the pharmacy to just give them 1 week at a time. And for methods with high lethality, you want to think about ways that someone else who's responsible can help them to secure or limit their access. So, for example, if they are considering a firearm, suggesting that they talk to a trusted family member to store the gun in a secure place. If their parents have guns, talking with them about get permission to talk with their parents about getting them out of the house temporarily, or what safe storage measures look like, biometric fingerprint safes, for example, that the youth can't access, or other types of safety measures. This is what the completed safety plan might look like with all the information filled in. And so you'll ask them, where they'll keep it, how they'll remember that they have it if they're in a crisis, how likely is it that they'll use it when they notice the warning signs, and how they might fight the urge if it's there to try to not help themselves, to let things get worse. And, again, it's a problem-solving conversation about how they'll use this if they're in a crisis. So what might be a barrier to using it, and help them find ways to overcome them. Can use this in the form of brief crisis cards. It can be, you can photograph the form on their and put it on their cell phones or other portable devices, as long as you have ready access to the written safety plan for the next time they might use it. It's a good idea if you have the opportunity to review the safety plan periodically with them. Discuss and possibly revise it certainly after each time it's used, But even if it's not used, to sort of talk about, is this still a good plan for them? Their circumstances and needs may change over time. And, you know, it's important if they don't want to do a step. They, you know, for sometimes with, you know, we see with very isolated people, they can really have no friends to list on the socialization with individuals section. Important to, you know, not apply stress to them to get, you know, to pick somebody to put on that list, but to talk with them about, okay, we're going to skip that step, and, you know, maybe we'll come back to it. Maybe one of the focuses of their treatment is to develop a friendship, because, you know, we know that peer relationships are protective, and then, you know, maybe eventually they'll be able to add somebody to that list. You know, that tell them that's a tool to help them, and, you know, although these are prescribed steps, they, you know, they can skip them if they need to, and especially if they're in imminent danger. They, you know, seek the level of care to keep themselves safe. Show you a video of Dr. Stanley doing a safety plan with a young Iraqi war veteran, and we'll come back and wrap up and take questions. The video lasts about 25 minutes, and you'll need to listen through the speakers on your computer. So if you don't have your computer speakers turned up, please do now, and you can put your phone down or put yourself on mute until the video is done playing. Okay, that was helpful for you all to see somebody filling out a safety plan with somebody. A couple things that we might change if we were doing that with a student. It's always a better idea to have the person who's doing the safety plan do the writing themselves. It gives them more ownership of it. So it's preferable to sit side by side and go over it while sort of pointing to the areas on the safety plan and having that discussion. And another adaptation that you might want to make for adolescents, when you're doing the section, identify the people they're going to call, who know what they're going through, who they've gotten help from before, instead of asking them, will you call them, and share this with them. If it's possible to do it from your office, call the people who are on the list. Let them know that they're working this and they're putting them on the list because they're going to be a support to them if it happens in the future. Whether it's a parent or an aunt or an older sibling who's away at school, or somebody who is a bit older and a bit wiser, and something that they can call crisis. So how effective these safety plan interventions are. Dr. Stanley interviewed 100 veterans who were given it in the emergency department between 3 months and 2 years after they had done it, and they all remembered they had done it. They all could say where it currently was. 91 of them felt it was very helpful in making them feel connected to the VA, and so that's that motivational enhancement for continuing to come for care. 9% of them said they'd recommend it to a friend, and actually 6 had already told a friend about it. None of them thought it was harmful. A few of them felt it was either too long, didn't help them with their anger enough, or found it difficult to use when they're depressed, and we would expect that. When asked which parts of the safety plan they felt were the most useful, a majority of them felt that identifying things they could do all by themselves to help them to, sort of relax was the most helpful section, followed by going and doing things that are social. So it's interesting that the majority of them, liked those non-clinical interventions the most, found them the most useful. One noted they don't realize what to do when you're in that situation, and having planned activities like going to a coffee shop, remembering to breathe, are effective. Said things like, it helped me not be such a tough guy and actually go for some help that I needed. I'd tell others at risk it saved my life. I never thought I could do anything about my suicidal feelings. Now I feel I'm not at their mercy. It helped me. It saved my life more than once. Very helpful, especially with people going through depression, showing you and telling you how to use different coping skills. It gave me the opportunity to more clearly define signs when my mood is beginning to deteriorate and when to start taking steps to prevent further worsening. And I like the safety plan. I hung it on my wall, and it helps me remember how to deal with things. And it occurred to me before that I could do something about suicidal feelings. This safety plan is currently in use throughout the VA in many emergency departments that are non-veteran civilian emergency departments. It's used throughout the New York State Office of Mental Health in all their outpatient clinics, and in many other parts of our communities across the globe. It's a best practice on the Suicide Prevention Resource Center and American Foundation for Suicide Prevention Registry of Best Practices for Suicide Prevention. And if you want more information on the safety plan, you can go to www.suicidesafetyplan.com, which is is the website where you can reach out to Dr. Stanley and Brown, and you can get more information. This webinar is considered a a good introduction to safety plan writing, and people do write the safety plans without even having this type of introduction. But there are additional super user trainings that you can access from Dr. Stanley and Brown, where they'll actually teach you how to evaluate safety plans for accuracy. They sort of score them when they're looking at whether they were done correctly. And so if you're going to be supervising folks doing these, you might want to get in touch with Barbara Stanley about participating in one of those high-end user trainings that they have. But I'm happy to answer questions, any questions that you might have now. If you want, you can type them into the chat box, or I want to take everyone off mute because sometimes that can be quite loud. But I will take off of mute our other hosts.
Hi, Adam. Thank you so much. I think this is Megan. I think this was a specific overview. What is a free resource to us, which is fantastic. I think, thinking about the steps within the safety plan, if your organization has provided training, such as applied suicide intervention skills training or assessing and managing for suicide risk, there are safety plans that are built into those. And so, this isn't necessarily to replace that, but a reminder of what the important components of a safety plan are, and it put into your system. Also for supervisors, I think once the organization decides to use a safety plan template, how would another staff member, maybe in another appointment, know that that safety plan has been done? How is that kind of been or flagged in an electronic health record? How would staff know to, as Adam said, kind of checking in on the safety plan periodically is important to do. I also just wanted to say, in terms of that, kind of for our contact, we're so fortunate to have the Youth Line by Lines for Life, where actual peers answer calls, texts, or chats between 4 and 10 p.m. If you just Google Youth Line, you'll find the phone number, but I think more applicable for who serve, they have a text line, which is such a fantastic resource because we don't want to call. Also, in those, when you're doing the safety plan, call the National Suicide Prevention Lifeline or call or text the Youth Line with youth. I think that just is one way to break down barrier to something that can seem really scary. So you just call, tell them, I'm with someone that's going to be giving you guys a call, and we just wanted to know what it was like, what happens when we call, what you ask for. And so I think that's a great way to kind of break down some barriers.
Great. I think, sort of next steps involve thinking about the nuts and bolts of, who's going to write these, how you're going to document these, how they're going to be used in practice. Well, nobody any chat questions. If that's the case, we can end and give you a few minutes of your Monday back to prepare for your day. I know it's about the start of your workday there. And yes, we'll be more than happy to talk more about this and about the CSSRS when we do our webinar following up on CSSRS. So thank you all for the time and attention. It's appreciated, and all of the hard work that you do on behalf of the youth of Oregon is also appreciated.
them.
Okay, Tara, bye-bye now.